The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code PhysioCoach2MO, that's PhysioCoach2MO, to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's better physio. I'm going to start the episode by admitting something vulnerable here, that it was only a few years ago where I really understood what hip dysplasia was from a clinical perspective. And it was only 3 minutes ago when I realised what the word actually meant. Because it turns out it means an abnormal growth of cells. And we were discussing here, myself and Yasmin Palfrey, advanced practice physiotherapist, who's our guest today. We're discussing what that really meant in terms of our physio practice and diagnostics and language. And then I suddenly realised I didn't even know what dysplasia really meant. I've for many years rebranded this now. Since I learned what it meant in practice, I learned that it was easier to explain it to a patient in instability terms, just like we do with the shoulder. We call shoulder instability. We don't say shoulder dysplasia, even though for some of those it quite likely potentially is a dysplasia, an abnormal growth of cells or tissues around the developmental phase. So perhaps one of our issues here in the reasons why dysplasia takes, I think it's on average 9 years to diagnose. Maybe one of our issues here is that no one really understands what it means, and therefore we get taught it at some point in our studies, and then we forget all about it because it doesn't stick.
Agreed.
The language of it perhaps I think is more important than the thing itself, and instability immediately makes sense to us. We get that, and although there is an importance to wrap some reassuring language around it for a shoulder, you can make someone worried and fearful if they think their shoulder's going to fall out at a gust of wind or whatever. We know that a hip dysplasia is very unlikely to dislocate at a gust of wind or whatever exercise it might do. So it's important that we can wrap that appropriate language around the term. But I've been explaining it as instability, and I've had no issues with my patients suddenly being fully fearful around it. So Yasmin, a huge chunk of your caseload is female hips. So as a result, you see a lot of hip dysplasia. I'm sure you're more knowledgeable about it than I. But tell me about some of the things that you've learned over the years of dealing with hip dysplasia.
I see a lot of female hips in clinic, and to be honest, I was a little bit like you. Even probably like 4 years ago, I didn't really know what hip dysplasia was, and probably saw a lot of cases of hip dysplasia but missed it. And so it's not until I went on courses myself and learned about it and then realized that, I'm probably seeing more of these patients than I think I'm seeing. But for me, hip dysplasia is the abnormal coverage of the femoral head with the acetabulum, and it often comes with like hypermobility in patients, which we know we see a lot of female patients with hypermobility. And actually it's the female patients that are more likely to be dysplastic. So I think it's 80% of patients that present with dysplasia are female. So that's why we tend to see more of that in clinic.
And once we've got some diagnostics in place for these females, there's a good chance that if they're average, that it's been a long time that they've been misdiagnosed or not diagnosed at all. What are you then going to see in clinic? Like, what do they present with? What are the signs and symptoms for these cases?
Often they will come with pain, like in their hip, usually anterior and posterior hip pain. They might experience symptoms of the hip maybe catching or feeling a little bit unstable. They'll often have pain when they're standing for long periods of time, I've noticed as well. But for me, it's the history is the key, that maybe they've had their pain for 4 years, 8 years with no improvement. And in some cases, they've had injections and physio and it's made it worse. Often the patients who have had diagnostics, it will come back as maybe they've got some impingement in their hip, or you'll see a labral tear. And actually they haven't had the right imaging to have further investigation on the hip, which is usually an X-ray and maybe not an MRI. But yeah, for me, it's the history more so that will make me alarm bells ringing when someone comes, they've got hip pain for 4 years plus.
Yeah. And what will you then be thinking about regarding management for these people? How does that differ to an average impingement type case?
Yeah, so first of all, I think for me, it's in terms of management, it's thinking about, well, what have they done so far and what can I maybe do differently? So in terms of the rehab, I would still be wanting to work with these patients on working on that stability around the hip, working on their smaller muscle groups. Often patients with dysplasia will come to me because they might be in their 20s or their 30s. They haven't massively had a huge amount of hip pain before, but then they've just decided that they'll run a marathon or something. They start training and then they start getting this hip pain. And yeah, for me, it's all about thinking about what triggered it and then how we kind of go from there. But we do know in some cases with dysplasia, surgery is the option, and patients will sometimes come to me post PAO surgery, or they might actually come at a stage where they have early onset arthritis because of the dysplasia as well. And again, that might be managed differently, input with the consultant as well, and maybe unfortunately surgery and then rehab post that.
When I'm thinking of shoulder instability rehab, I've got this number in my head of it takes 6 months. Like it's a 6-month journey to develop the stability in order to get the outcomes you need. Is it similar with a hip? Are you using kind of those time frames?
Yeah, I have patients on my caseload that I've been seeing for 9 months with physio. So I definitely want to be really clear that it's not a quick fix, especially if they've had pain for a really long time. I had a patient on Tuesday actually who had childhood dysplasia and has had hip pain all her life, and she came to me with a flare up with her dysplastic pain. She doesn't want to have surgery. Her last MRI said that she had quite bad osteoarthritis of that hip as well. And she's terrified of even doing an MRI. She's terrified of having surgery. So for her, it's going to be, she doesn't have to have surgery if she doesn't want to. So it's how do we calm that hip down? So for me, a lot of it is load management, thinking about positions that might aggravate it. It's often lots of sitting, sometimes like hip flexion, and just doing maybe a little too much. So I'm working on, how we can then get that patient back to some, maybe she's not going to have a perfect hip and she might always have a little bit of discomfort, but how can she continue with her job and continue with the gym, and then perhaps see where things go for that type of patient.
So another vulnerable moment for me here. It was only recently where I knew what a PAO was as well. I would say I was maybe even 10 years into my career before I knew what it was. Do you mind just spelling that out for our listener as well, so that they can learn a little bit sooner than I?
So it's a complex surgery and it's often done in younger patients or adolescents, but you will see it happening in patients that are adults as well. And it's a surgery where essentially they kind of cut and rotate the bone to allow for a bit more coverage of that acetabulum.
Yeah, so it's creating more stability biomechanically then, so exactly. Less chance of that instability. I'm going to keep using that word because I think it's better that we almost rebrand it here. Not that it's necessarily my role to, but just for the kind of more simple-minded like myself, like it makes more sense to me when I think of it as instability.
So, it can often come with complications. I think often patients will struggle with like bone healing. I have quite a few patients for me that will go on and they'll have they'll have 2 surgeries because of it, and maybe things like infections and things will happen. I've had cases like that before. I wouldn't say it's an easy surgery from the patients that I've seen post-surgery, but it's actually can be an amazing surgery, and it's actually probably one of the only surgeries that we've got that can reduce the risk of osteoarthritis in the future. So that's a big thing for these patients.
I guess it's similar with the tibial osteotomy, where the way they do the knee preservation, which again was like when I heard about that, it sounds barbaric in the way that they do it.
Yeah.
And it's a huge surgery for people to go through. But as a result, it completely changes the biomechanics of the joint and could be a really significant step towards preserving the joint. So yeah, similar thing at the hip and the PAO. So look, what I find interesting as a generalist myself is when people almost develop these specialisms within their career, and you enjoy working with hips and specifically female hips to some degree. How did that come about? How did you end up realizing, or did you fall into it, or was it a more purposeful step towards becoming a hip specialist?
I guess I fell into it at first, and then it became something that I purposely kind of went for because I found it interesting. So I was really lucky when I was a Band 5 physio. My first mentor I met was a hip specialist. So his name's Benoit Matthew, and he was really, really great to me. So he would asked me to come along to his courses, and I'd help him out in exchange for attending some of his courses. And that's how I first started learning about the hip and realizing the hip isn't just arthritis and gluteal tendinopathy. There is so much more. I think what we learn at uni is like just barely scratching the surface, right? And you realize there's a whole textbook on the hip or more than that. And so I was like, wow, the hip is complex. And I found it really interesting. And that really got me into it. And then as a female physio, I think I see a lot of hips as well, because I think a lot of the injuries that we see in clinic when it comes to hips in females are things like gluteal tendinopathy, proximal hamstring tendinopathy. They are more common in females. And so naturally that was coming through my door a little bit more. So yeah, I think that's kind of how I got into it. And then I've tried to go on every course I possibly could regarding the hip. And yeah, I've had my own hip pain as well. So hip impingement, classic hypermobile patient as well. So yeah, I think that's kind of the reason why.
And we covered a bit in our preparation for this about the paradox with female physios that our profession is still predominantly females, that is 75% females, but private practice, to our experience, we both work in private practice, feels a little more male dominated. There weren't any stats available for it. There is a bit of a shift happening. We then looked it up because we were having this conversation about it. We both looked it up together, and there seems to be more males on the at university now compared to females. So I think it's shifting towards more 60-40 females or 65-35. And yet when I look on Instagram and scroll through different content creators and different sort of influencers, I guess, within the physiosphere, it still to me feels male dominated. And that may be because my algorithm is telling me that I'm listening more to males, which is a shame. I hope it's not that, but I wonder whether there's also a lack of females that are putting themselves out there and being brave and posting all this content. Because I know for me, when I post content, I still find it terrifying. I still really struggle with it, and it's I'm getting better at it. It's a skill that I'm learning, but you've really nailed it, right? You've really got this great profile, some really cool content out there, and you're putting your head above the parapet and really kind of representing the kind of female physio side. What's your sense of it and how that paradox really exists there, the female male paradox in practice versus online?
Yeah, I completely agree with you. I think from where I sit, I think particularly on social media, the big accounts that we see that are doing really well with physios, with and also teaching courses and doing all of that great stuff, I think I see more men doing it. But you're right. I think when you look at the NHS and you look at private practice, I think perhaps there's quite a lot of representation of women when you think of physio as a whole, right? And actually, bands 5 to 7, you'll see actually predominantly female physios in those roles. But then when you look beyond that, there's a little bit of research around kind of the gender pay gap and really physios that go beyond maybe into clinical specialist and consultant roles. We actually see less females, women in those roles. And so I think that then trickles down to seeing those kind of clinical specialist roles, and maybe reaching out for doing those extra skills, things like injecting, things like scanning, prescribing, because I certainly didn't feel confident to do those skills when I first graduated. It's only really I've got into my 30s and I felt like I can afford to pay for those courses, have the time to do those courses and feel like I'm ready to do them. But usually when you're in your 30s as a female, we're starting to think about maybe having a family and you've got childcare duties as well. So I do think that makes it perhaps harder for women to then be able to have the time and finance to be able to do those skills that I think, then require you to then become a clinical specialist or a consultant physio.
And it's important because if you've put your head above the parapet and said, I'm going to be a clinical specialist, then you sharing that message helps to give encouragement, or you're then a role model for other women physios, which, I really hope it does carry on that way.
I do think imposter syndrome is a big part of that too, though, because I think when there was a really interesting study, and I think you'll probably be aware of it, but it looked at people that were applying for jobs. And so they had a job spec, and the job spec showed like maybe 12 points or something of what you needed to go for that job. And they found that actually the men that were looking at those job specs, if they didn't meet a couple of things on that spec, they'd think, do you know what, I think I could probably do that. I've got the transferable skills, I'm going to apply. Whereas the women that were looking at that job spec would think, oh gosh, I can't do that one thing, I don't think I'm qualified. And that, I think, has got something to do with imposter syndrome. I think we probably all experience it, right? When you invited me here today, I was like, I don't know if I should do that. You've had some great people on the podcast. I don't think I am good enough. And then I now, with experience, will use that as a sign that I should probably say yes, even if it feels scary. And so, I think, imposter syndrome is a tricky one to work with. But how do we kind of get ourselves out of that and build confidence as women in healthcare?
Well, the best definition I heard of imposter syndrome was that when you don't feel the confidence to do something when everyone else around you already believes that you can do it. And that mismatch is the experience. If someone's asking you, like in this podcast situation, right, I know that you are more than capable to sit here and be an expert on this show, and yet that experience wasn't quite what you had, but you had the bravery to kind of overcome that and step outside the comfort zone. And the other nice definition of comfort zones, like outside the comfort zone is the fear zone, outside that is the learning zone. You then create a new bigger comfort zone by going through those, and you just keep doing that in your career, and you grow more and more confident and more skilled, and your scope of practice grows, all these things. So
absolutely.
I think that I've done the same as you. I definitely feel a lot of fear when I'm outside of my comfort zone, but it's worth it for me. There's a huge purpose towards what I do. I think it's a really important thing in my career. I mean, others might disagree perhaps, but I love what I do, and I think there's a real purpose to it. And as a result, I'm willing to go outside of that comfort zone. And I hope more people do, especially based on the theme of what we're talking about here, especially women. I really, really want to hear more, because we do have different experiences of the world. It's important that we don't just have men on this podcast or men on Instagram or other social media talking. We want to hear like what's it like to be a woman in healthcare, and I think it is a different experience.
Yeah, I would love to be able to inspire other women to be able to have the confidence to come on something like this, or whether it's applying for a job or reaching out for a mentor, or I don't know, posting on social media when it feels really scary and embarrassing, but doing something that they want to do, but maybe they didn't have the confidence for.
Well, the cool thing about what you've done is that you aren't just a physio, right? That was something that was very clear to me, is that you've curated your career based on what you like doing, based upon your physio expertise, but it isn't just delivering physio sessions, right? So in our modern era, we see that across the board in different domains. There's lots of people that make money through social media, that make money by being consultants for other brands. But in physio, that's not necessarily been a typical career pathway. So I'll tell you what, let's go the long way. If you could speak from the beginning, Tell us about your journey into becoming a physio, first of all, and how that mapped out into you having this diverse career now where you're physio, consultant, social media. Well, tell us the journey of that.
So I guess if we go right back to when I started physio, or should I go back to when I started and decided to be a physio? What would you like?
I think tell us about what life was like at school for you.
Okay, fine. So when I was at school, I didn't do very well. I probably came at this from a very, it wasn't a simple way to get to physio, I don't think. But yeah, I did poorly at school. I went to a failing state school and really struggled to learn there. I think I probably had a lot of anxiety as a child that maybe wasn't picked up. And yeah, I found school really hard. And then I kind of stopped going in year 10 and nobody really knew. And I really enjoyed being with my friends, going out, and school kind of just wasn't that important for me. So I left school with pretty much no education and no GCSEs. And then I did lots of jobs. I went traveling. I worked as a waitress and realized that I really like talking with people. I'm good with people, and kind of excelled in waitressing. And then years before that, my dad had had an accident. So he's a cyclist, and he'd got knocked off his bike by a big Jeep, and he had multiple injuries. He had a back injury, ACL injury, rib fractures, shoulder fractures, rotator cuff, like you name it, he got it from that injury. And I'd gone to some of his physio sessions at the local hospital because they'd occurred during summer. And I guess at that time, I didn't realize that's something I wanted to do. But on reflection, I've realized that actually, I remember walking into that hospital and seeing some of the women that were treating my dad and him going to hydro and just thinking, oh my God, that's really cool. But yeah, it wasn't until years later. And then I remember I was sat and my mum was like, we kind of need to figure out what you're doing here because you're 23 or 22. I can't quite remember, but I was a bit lost, a bit depressed. My friends had moved off. They'd gone to uni, or they were leaving uni and moving to London. And I was like, I'm still here doing the same thing. So I was like, okay, I'm going to go for physio. Then I kind of remember my mum being like, how are we going to get there? That sounds like a bit of a challenge. And I was like, okay, so I went back, I got my maths GCSE, and I did that at just the local college alongside work at night school. I did that within 6 months. I managed to pass it. And that was a huge thing for me. And then I did an access to science course. I hope they still go on those courses because that was amazing for me. And I did really well because I enjoyed it. I did biology, psychology, and physics. And if anyone knew me and thought that I would actually end up learning that, they would have laughed, I think. And I was probably thinking I was just so unconfident in those types of subjects. But yeah, I did well. And then I got into uni and I went to MMU in Manchester. And again, I did really well at uni. I graduated with a first, and then I really built confidence around education and myself and what I could do. So from a person that was, quite anxious and felt quite rubbish at most things they put their mind to or not put their mind to, but then leaving university with a first, honestly, it was just, a big thing for me. So I went to uni. I got into MSK straight away. I definitely knew I didn't want to do ward work from the placements that I've been on. I have been on a really inspiring placement in outpatients, and some of the female physios there were clinical specialist physios. They were injecting and they were, prescribing and doing ultrasound, and I shadowed them and I was like, that's what I want to do. So when I got the MSK job, my plan was that I would join the NHS, work my way up, and then become an MCAT physio or clinical advanced practice physio. That was kind of how I got into MSK and outpatients. So, yeah.
It's clear that you didn't just want to be a physio, though. There was this other passion that was in there, or this maybe more of a curiosity to do other things beyond the one-to-one sessions. How does that come about when you're going through the traditional route of MSK physio, you're in clinical practice? How does it come about that you then start to develop this curiosity for other ways of pursuing your career?
Yeah, I definitely think shadowing other physios and mentorship has been a big thing for me. So I've been really lucky that I've been mentored by 2 really great physios, and I've also had great supervisors in the NHS that would, help and support you with kind of thinking about your career progression. But yeah, I think mentorship has been a big part of that, and seeing where you can go with your career and aiming for the heights of that, hopefully. And I think with physio, when I left the NHS as a band 7, and I had really wanted to stay and actually kind of continue and do all my courses within the NHS. But by the time I got to band 7 level and realized that actually I think it's going to be quite hard for me to do that here because of, funding and clinical need, and the kind of hierarchy and difficulties that happen in the NHS, I decided to leave. And then I've gone into private practice and realizing that, those are the kind of things that I need to be. If I want to do that, I have to kind of maybe do it myself and be able to fund that and get the supervisors and do all of that sort of stuff myself, rather than waiting for someone to give me the go ahead that I'm now allowed to do that course, or I'm now allowed to go and try this new skill.
As with any practice management system, Jane is full of reports. So there are quite a lot of reports that you can run. I've just got a list of them here. So one of my favorite ones is the duplicates report. So the duplicates report helps to match up duplicate patients. So often when people are online booking, they don't register through their old case, they just set up a new one, and it can be a bit confusing at times when you're trying to find notes from a previous case. So that helps you just match up that case instantly, really quick and easy report. Another one I've used recently is when we were just looking at some of our marketing that we were doing, and just trying to see what works, what doesn't work, and really quickly I was able to see our top clients, how they came to us, where they heard about us, how many sessions they'd had, the revenue that brought into the business. So that was another really helpful report. And another one that helps me really quickly stay on top of the performance of the team is the product performance report. So you click on that, you can either see the whole business, how many sessions are happening in a time frame that you're looking for, or an individual clinician, you can have a look, see how they're getting on, how many initial assessments, how many follow-ups. You can break it down by how many sessions they've sold or how many packs they've sold. So a really good way of breaking down how people are getting on, how people are progressing. And now we're getting back to the episode. And you're now an advanced practice physiotherapist. Mm-hmm. What's the process like for doing that? I know I looked into it a few years back, and it wasn't something I decided to do. I think I was thinking more businessy at that time, so I wasn't sure it was for me. But what was it like for you when you were making that decision about progressing clinically? How do you go about doing that, and then what does it then mean on the other side of it once you have that title?
Yeah, so for me, it's having the clinical experience, and then it's also having the extra education behind that, right? So I have just finished a PG cert in ultrasound, MSK ultrasound. So that was one step at kind of heading that way. My plan is then to do injecting and prescribing. So those advanced skills are a big part of it. But also I think specialism is important in private practice for sure. I think to be advanced at what you're doing, perhaps having the skills maybe in a particular area. So for me, that is the hip. And now people come to me for particularly just the hip, right? And that's what, I really enjoy treating. And so I feel like I now have the advanced skills, I have the background, the education on that to be able to deliver that. I guess in private practice, it does look different though, doesn't it? Because in the NHS, you're kind of given that role and you go from 7 to 8 to MCAT, whereas in private practice, you're kind of,
It's intentional, isn't it? I think that's what I realised is that we came, both clinicians in private practice, and there's a crossroads. Do you carry on in one path, or do you shift over to the advanced practice pathway? And it's very much suits the specialism side of it. I can see that for sure. And when you're specialising within the hip in this advanced practice role, I guess not only do you learn what dysplasia is, but I imagine there's sort of other diagnostics and therefore treatment plans and treatment interventions that you get really good at. So what are some other classic second opinion stuff that you see that isn't as obvious to perhaps, the younger you, the newly qualified you?
Yeah. So I see a lot of second opinion, even things just like gluteal tendinopathy or proximal hamstring tendinopathy. And sometimes it's down to rehab planning or load management and just simple things that maybe I'm not doing better than somebody else, but maybe it's the way that you're being able to deliver that to the patient and what I've learned about load management over time, or being able to kind of grade the exercises for a patient, I think can sometimes be helpful. So taking an example of like a gluteal tendinopathy, a deep gluteal pain, for example, I see a lot of patients that have been diagnosed as piriformis syndrome, or it's somebody who's had a wrongly diagnosed as a proximal hamstring tendinopathy, and actually it's deep gluteal pain. And sometimes the rehab can be too aggressive for a patient, and it's taking things back and trying to build up their load capacity on muscles that perhaps aren't irritating their problem. And so I think that's really with just practice. I think it's with repetition of seeing those patients as well. And I don't think it's necessarily just me that would be able to do that, because I think but it's seeing the patient, it's being able to see where they are on that journey and what maybe exercises would be a good start for them, but also knowing like, okay, well, how do we refer on? Who do we go to? It's having those clinical relationships as well with consultants or other physios. I think dealing with hips as well, because I see a lot of female hips and let's say GTPS or glute tendinopathy, often there's like a hormonal driver there. And so I'm always trying to say, like, can we also maybe refer on to a gynecologist or a women's health specialist as well? Things I often see missed are actually endometriosis in patients, where maybe we're not asking those questions around, their pain comes on when they're on their period, and you realize actually that kind of hip pain might be more related to the endometriosis you didn't even ask that patient about. And so I pick those kind of things up a lot in clinic as well.
Is it just a case, how would you ask that in clinic in a way that the listener can then go, immediately take that and go, I need to ask that better? Because I think generally men aren't very good at asking this stuff, right? It can feel uncomfortable for us to ask women about their period. How would you ask it in clinic?
Yeah, I think I feel quite confident in asking it, just like we would with like maybe our cardio equina questions. They can feel quite weird to say, right? Asking somebody if they've got numbness around their groin can feel a bit scary, or they have erectile dysfunction can seem scary. But I think it's how you land it. And so I'll usually start it with, I'm going to ask you some questions now around your cycle, and it's not to be intrusive. I just need to know, because sometimes your cycle really matters when it comes to injuries, and so it might give us a little bit more of an understanding about what's driving your pain. And so that's when maybe I would lead in with like menopause questions or missed periods for things like relative energy deficiency, or if they've had any other issues like endometriosis and past medical history. Because I think maybe women, if you do ask past medical history, they kind of sit down in front of you and you think, okay, so have you had any other, heart problems, lung problems, or any other injuries? We might be used to asking those questions, but I don't necessarily think that patients will always give you like, oh yeah, I have endometriosis actually, and I'm having some investigation for that. Unless you ask the question, sometimes it's left unsaid. And I've said it a few times, and patients have been like, oh yeah, I do have that. And so making sure you're always, just asking those. So I would always encourage people to do that. And I pick it up with things like dysplasia as well, asking the questions around, did you have any childhood hip pain, and did you have to wear calipers, or were you ever in supports? And often they're like, no one's ever asked me that question before. That's really interesting. And it's the first time then you can pick up something else that maybe you don't need to manage, maybe you need to refer on. But if you can be that person, then I feel like you've done a good job.
I've found a few times that I'll ask a question like that, and in the moment they'll say, oh no, yeah, I don't notice any pattern there. And then they come back the next time, and because you planted the seed about it, they then go, oh, do you know what? I have noticed, because they wouldn't have thought to join the dots. That's our job, to join the dots. But once you've raised it as a possibility, they then start to do it. And it's not just with cycle or anything specific about that. But if I'm asking about stress, if I'm asking about sleep, and then they come back and go, oh, do you know what? I have actually started to notice that now, because you make it easier for them to draw some form of conclusion.
Yeah, exactly. And so, I think it's just having that understanding, knowing those questions. And maybe sometimes as a junior, you have so much to think about, don't you? As a junior, so many different areas, so many different things, and you're just trying to learn the basics. But I think if you can have a list of questions and then something that you can maybe keep somewhere in a folder on your laptop and be able to say, okay, hip comes in, I'm going to ask these key questions.
I spoke about this on a podcast recently. I think it was the last one with Tim Beams, and we were speaking about having a protocol for how we go through our initial assessment. And I don't have that anymore. I feel comfortable to move around in my own brain and find what I need in the moment. But I definitely used to. And I think that's the process that we sometimes go through, is we might need prompts earlier in our career. And as you get more skilled, you can then be more in the moment, more present, because you've got more flexibility within your mind to draw on those experiences.
Yeah, agreed.
I was also thinking there as you were talking that endometriosis is another one of those definitions that I didn't understand. I didn't know what it meant, and I'd hear it a few times. And it took a long time for me to really understand that. And it's also not really been spoken about much, maybe more in the last 5 years, perhaps. I feel like that might be a bit more, but certainly in my earlier career, I'd hear it occasionally when someone would tell me, oh, I've got endometriosis, or I'm being investigated for this. And then I'm then going to my laptop or computer afterwards and looking up what is endometriosis. So it might be worth you just sharing very top line, like what is endometriosis and how can that then affect MSK conditions for some people?
So it's the abnormal growth of cells, and essentially patients will sometimes experience lots of discomfort, heavy periods, painful periods. That's probably one of the main signs of somebody having endometriosis, that it can just be awful for a female, the type of pain that they were experienced during that time. But it can sometimes cause hip and back pain. So I've had patients where the lining of the womb from the endometriosis then kind of goes around the sciatic nerve, for an example, or they will get lots of kind of groin pain, discomfort. I've had patients that have had ovarian cysts, and actually that's what they come in, maybe with some anterior hip pain, and it turns out that it's an ovarian cyst when they have further investigation. So it's just, I think, something to be aware of. It's certainly not everything that happens and comes through my clinic door, but I think we can often be treating somebody for back pain for a long time and they're not improving. And if we could just ask the simple question, then actually they might do quite well with other care or onward referral.
Yeah, I had one case in particular about a year ago where she had hip pain and occasional back pain, and that was the primary driver in the end. Endometriosis. I referred. I definitely didn't understand it well enough to diagnose, but there was a question that I asked around that, and it wasn't the first session, so I can't claim to be an absolute sniper on this kind of accuracy, but it was certainly a few sessions in and she was doing okay with things, but then she had this flare up, and then it was a follow-up question to the flare up. Oh, what else has been going on this week? Is there any other reasons why? Oh, I had a really heavy period as well.
Exactly.
Oh, okay. Well, that's interesting. Let's just monitor that over the next week or two and see if it settles down. And then let's also get you into your GP, and I'll write a letter. And then before she'd had the appointment, it happened again the following month. And then it started to really make it a little more obvious. But she'd had this hip pain for a couple of years and hadn't drawn that pattern until I was able to at least ask a question, like you said, just ask, oh, that's interesting. Do you think that might be relevant? And then it turned out it was.
Yeah, absolutely.
What other, you mentioned actually about hormones and how that can affect some musculoskeletal conditions. Certainly tendons, I'm aware that they can be a factor. How does that play out in a pathological way?
Yeah. So, well, we know that as you're going through the menopause or your perimenopause, that estrogen is affected and your other hormones are affected, but that plays a huge role in your tendon health. But also patients that are in the menopause will sometimes get a lot of aches and pains. They'll get a lot of joint pain as well. And so it can play out in different ways, but I think it's just being able to highlight that with patients. So, you know, particularly if a patient's pain maybe isn't always fitting a clinical pattern as well.
Does that change your management as well if you're suspecting that it might be hormone related?
Not necessarily. So I think it's important to cover that with a patient and say, you know, you are currently going through the menopause. You've mentioned this to me. You're seeing a hormonal specialist, and just letting them know that actually this is why the injury might be one of the drivers, but also explaining that it's probably not just that. You've also mentioned that you were training for a marathon, but sometimes it might affect your recovery. And sometimes where we think that these tendon related problems in women can take a little longer to get better. And so just explaining that, I think, and giving the patient the education, and then if they wish, it might be a referral on, and then discussions with a doctor or hormonal specialist if they want to, but that's not always the journey that they'll follow. They still need, a good rehab plan that's progressive with tendon loading, and they still need load management and everything else we do so well as physio. So maybe the physio treatment doesn't change as much, but maybe my advice and my education would.
I can just imagine there that because there's a potentially longer journey for recovery, that they might be more susceptible to almost leaning on a steroid injection beforehand.
Yeah.
We know that there are some pros and cons to that approach, but I sense that there's more possibility that someone gets a little desperate of, it's taking too long, I need pain relief, and you can understand that experience. But is that something that you'll cover with your clients about the discussion around steroid injections?
Yeah, absolutely. And as someone who's obviously seen a lot of GTPS, which can sometimes, you still see the patients that come to you and they've just had a steroid injection into the bursa and their pain's not better because it's a tendon problem. But yeah, I think covering that with the patient is so important. Being able to then... Yeah, it's just the pain. The pain can be really hard for patients, can't it? Especially when they come to you with high levels of pain, looking for support and help. And then you're saying it could take 2 years. Quite a few kind of patients like that on my caseload at the minute. But there are other options for the patients as well. Maybe not just physio. Shockwave therapy might be helpful for pain relief. It can be maybe injections, things like maybe PRP or steroid injections, and in some cases things like surgical intervention. But I think if you're able to explain what some of the drivers are for the injury, sometimes patients will decide that actually they don't want those further management options if they kind of know why it's occurring and when the reason behind it.
I can understand it, especially because it's so commonly associated with sleep problems because they can't lay on that side, for example. I can really imagine the desperation that must creep in with some clients. Like their quality of life is significantly affected. In a way, these days I'm more open to that. It's like I know that there's some biological issues with steroid injection, but if someone's suffering, you've got to find a solution for them.
Yeah, exactly. I had a patient recently that had a steroid injection. They were actually also offered Botox as well for the hip, and that helped their symptoms. Once you're saying you get a lot of second opinions. What's classically missed in these gluteal tendons? What do you find that you're doing mostly with them? Yeah, so I think in these patients, actually, to me, a huge part of it is education and load management. So we often see it in the way somebody is kind of maybe moving through the world. Maybe they're a runner and their legs kind of moving into more adduction, or maybe they're walking that way, going up the stairs that way. It could be that they're sitting for a job, so it might just actually be managing their load around that, or, you know, how they're carrying their child, and, you know, the things that they do. I think that can make a huge difference in gluteal tendinopathy, which I think sometimes is underlooked, the load management. And, you know, in functional tasks, if you can change that, that can make a huge difference just in pain levels. And then once you've got that and you can settle down their discomfort, then I think, just like any other tendon injury, we want to have a progressive loading program. And I see a lot of females maybe being underloaded, I think. Just some bridges, a couple of clams. And that's a real shame, because I think, we know we've got so much research on progressive loading for tendinopathies, and just because it's a hip, and maybe just because it's a woman in her 50s, she shouldn't just be given, you know, body weight exercises. We've got to learn to work those patients hard. And so I find hip rehab quite fun and quite exciting, and going through like some quite challenging exercises with patients and encouraging them to lift heavy weights when maybe they would have been doing just some 5 kg dumbbells or something. And then you can get somebody to, you know, deadlifting 100 kg or something. And that's what we're aiming for. We need to get these patients strong. So yeah, I definitely think underloading is something.
The first part, I agree both. Let's just summarize that. I agree with both of those points. The first part I want to come back to, though, because we're in this culture as a profession where we are encouraging people to have lots of different postures. Just relax into your posture. There's no best posture is your next posture, and you can run however you want. There's no right way to run. There's no right way to lift. It's important that we move our body in lots of different ways. And I think sometimes we therefore almost underassess it, and therefore underestimate its potential for driving pain and driving problems.
Agreed.
So if what we have to be aware of here is what the thing you're describing there is that someone is spending too much time in a posture that is driving their problem, right? So sure, it's okay if they spend a bit of time crossing their legs one direction. Sure, it's okay if they spend a bit of time carrying their baby on one side. And by the way, if they're carrying their baby, that means they've had some recent hormonal changes, probably a deconditioning phase. So there's all this other complexity that comes with it, right? But if we're just staying on posture for now, we have to be aware of how they're standing, how they're sitting, how they're moving in the world. I fully agree with that. And I think we do underestimate its potential for changing pain. If we can help them understand what is driving that pain and how they can stand differently, that's an easy win, an easy early win as well. What people often haven't realized is that if they do offload or change posture in those moments, they won't feel pain quite so much, right? And that's what sometimes gets, I fully agree, gets underappreciated. Try to identify the pain producing posture and then giving them some different options.
Yeah, exactly.
And then the load side of it, bloody hell, I mean, you're preaching to the converted here about loading, but do you think that is true, that we underload women specifically? Do you think there's a factor there?
I think so. I think, I think I see that in clinic all the time. And I think maybe the certain person that's coming in with this problem, they're going to be in their 40s, 50s. And from what I know about my mum being that age, she didn't grow up with strength training. To her, it's really foreign. And if we go back even to my grandma, like they would never have done anything like that. And so you also have to be maybe educating someone around strength training as well, which is kind of, I think it's a big job in itself, right? And so you have to then be having the time with patients to be able to explain why they need to get stronger and why it would help. I don't think maybe we always have time for that in clinic. So I think maybe time is part of it. But also, I'm hoping that we don't think that maybe women are not able to do as like heavy loading as men. I don't think many physios would think that. But I think it's just, it's just how people kind of come in and what they're expecting from the treatment. And we see a lot of women maybe doing yoga and Pilates and stuff. So it takes a lot of energy to change someone's mind on something too.
I think you've hit the nail on the head there, is that it requires a more skilled practitioner, a more skilled communicator to get across the importance of this. And to change someone's mind on it is important. Whereas a lot of men even if they don't do any weightlifting of sorts, they would probably go, I should lift weights. They would probably say that. They know they don't, but they know they should.
Yeah.
Whereas women might not go to that. So you're then having to change an entire belief system, not just tweak their gym routine, which a man comes in. Sometimes that's all you're having to do. It's like, great, you're going to the gym 3 or 4 times a week. Excellent. Yeah. I just want you to do this instead.
Yeah.
And then okay, that's easy. And off they go. Whereas I agree with you. I've had that in clinic too. You're more likely to have to spend maybe several sessions working with someone and discussing the benefit and helping them see that what they are able to do with body weight or at home may be insufficient for achieving the goals. I even think that that's sometimes why these conditions take longer to fix, is that they don't get exposed to the sufficient load, and therefore they take longer. So they've got all these things going against them. They've got society's expectations of men versus women training in different ways. You've got hormone changes. You've got postural differences in the way that the expectation, maybe even carrying kids, right? You've got childbirth as a result of, and therefore changing hormonal changes. So you've got all these factors that do mean that women are different to men in so many ways that I certainly didn't appreciate for a very long part of my career.
Yeah.
And I'm glad that we're talking about it now.
Yeah, definitely. I think it's so important. And if we can just hopefully encourage other people to ask these questions and persevere with this kind of stuff, then I think it can make such a huge difference. Sometimes I'll even just send patients TED Talks on why strength training is helpful. And just being able to just give a bit of advice, at least knowing that you've really tried to teach somebody what they should be doing.
There's also this nervousness about being in the gym still for many women, is that part of my role often is to spend a few sessions coaching them through some sessions in the gym that's rehab oriented, but just to help them feel comfortable using the machines and being there. I've had a few women, that's the reason. I asked them, what is the reason why you wouldn't do this? And it's, I really don't feel comfortable going there.
Yeah.
So there's still a shift that needs to happen there as well. Yeah,
absolutely. Not feeling comfortable. It's often referred to as the men's room in the gym. Yeah. You know, I wouldn't go over to that side of the gym because that's the men's part. Yeah. It's got all the men's stuff in. And I hear that all the time. And still, unfortunately, you hear people saying, you know, I don't want to get bulky. I don't want to put on muscle. No, I wouldn't like that, you know. And so we've also got the societal pressure still of being skinny, of looking maybe like Kate Moss, and you know, and a lot of people will think that weight training might actually do the opposite of what they're hoping for and how their body looks. So again, it's educating around actually strength training. It's probably not going to do that. It's going to take a lot for you to become very muscly.
Yeah. One of your other interests I know is running as well. What do you often see regarding the hip and running? What kind of stuff will come about as a result of people running?
So I guess, well, because of the hip, I'm seeing a lot of bone stress injuries. I just sent one for imaging and to a onward referral just yesterday for suspected femoral bone stress injury. But yeah, other than that, hip impingement, I see a lot on runners as well, labral tears. And it can be tricky in clinic diagnosing these patients, because sometimes I've been so certain a patient has a femoral neck bone stress injury and then actually it's impingement. So I think
you'd rather that way around though, right?
Yeah.
You'd rather miss it that way around.
Yeah, absolutely. And it's I still pull my hair out just thinking about the amount of patients that have told this got a hip flexor pathology. Still that's happening. I had a male patient come yesterday and he's been having hip pain for 4 years, and he's been doing hip flexor rehab for 2 years, putting a kettlebell on his knee and just going up and down. And I'm thinking, how have you still been doing that for 4 years for a hip flexor tendinopathy? It's probably not that. So having that discussion with patients, and seeing that a lot in runners.
Similar when someone's say, I've got really tight hip flexors, and they do a leg press. They're like, yeah, there it is. There's that really tight hip flexor. And you need explaining, well, actually the hip flexor's in a shortened position at that point. You're likely just squashing your femur up against the acetabula there, I'm afraid.
Yeah.
So maybe that position is not for you.
Yeah.
Let's use that example. You mentioned the guy came in yesterday, he's been doing 2 years of hip flexors and stuff. How did you shift that narrative for that particular patient? Where did you go diagnostically, and then what was your initial management plan for someone like that?
Yeah, I think with this patient, so my initial thought, he's come through the door, he's mentioned that he's had this hip pain for a long period of time, but it's getting worse. And so his initial kind of presentation was basically, he took his hand and he went, my pain's here, it's my hip flexor. So this kind of classic C sign that we see with like a hip impingement pain. So already I'm thinking it's probably maybe intra-articular than it being the hip flexor. And then in terms of my kind of questions, it's asking what kind of functional positions might be uncomfortable. And again, then he's like, yeah, in the gym, I don't like deadlifts. Actually, I've stopped doing those. They make it sore. And again, so my mind's thinking, okay, perhaps this might be more impingement. We're heading down that route. Again, just going through history, though, is important with this type of patient. So I don't have the diagnostics back from what's going on just yet, but making sure that we're ruling out bone stress injuries. And, you know, my index of suspicion for that at this time is quite low just because of how long he's had pain. And he didn't have a mechanism of running and things like that. But yeah, I think it's really delving into the patient's history, the subjective, and then going through special tests with the patient. So all of your impingement tests and deep hip flexion, rotation, seeing if that is flaring the patient up. But it can be tricky when also we know that those tests will also be positive if there was maybe a bone stress injury or if there was also a labral tear. But I think, yeah, it's just being able to feed that back to the patient, what you found on that investigation. And education for me was really important there. Being able to explain that, you know, why it's probably not the hip flexor, and how, like you said, how the anatomy of how it works when he's, you know, when he's moving. And yeah, I think particularly with this patient, he got on board right away because he's able to be like, yeah, actually, on reflection, it hasn't been working for 4 years. And then you feel quite sorry for the patient that they've been blindly following a program without any change.
So is he still doing his hip flexor strengthening at this point?
No, not at all. So we completely changed the management, and obviously I've taken away most hip flexion stuff for him for now to try and settle it down. Again, same thing, load management. Classic patient that's come in with a lot of weakness in external rotators and abduction. So it's a nice entry point for rehab to start building up the capacity of the hip. And yeah, hoping that that helps this patient more so than the other exercises. I
think the confusing thing for a less experienced and non-hip specialist physio is that often they do have some pain on resisted hip tests. And they may well have some secondary hip flexor tendon or muscular symptoms that a little bit like the long-headed biceps. Like, it's quite rare the long-headed biceps is a primary driver of a problem. It coexists. So we then treat it as if it's this issue, but it doesn't get rid of everything. It might help a bit and then it stops helping because there's usually something else underpinning it, right? So that's what the extra detail is about, is being able to try to see the wood for the trees, right? Is it just this, or is this a symptom, or is this the cause of what's going on? Certainly, I mean, we don't know the full story. Maybe this guy went to one session and didn't sort of follow through. Who knows? So we don't want to like bash the physio necessarily, but certainly I would be thinking about really trying to establish cause and effect with these cases. Like what is really driving this and underpinning it, and that's where, you know, we started with it. Dysplasia really is key here. What's really underpinning these impingement type symptoms, this anterior hip pain, the intra-articular pain? What's driving that? Why do they have it? And the clues start to lie in the story. You know, are they hypermobile? Are they stiff? Do they get it in these unstable positions? Do they get it in posture? Do they get it when they're loading something quite specific, like a direction of pull, or as you were mentioning there, the deadlift? Is it deadlift or squat pattern related or leg press related? You start to develop this picture of what really drives it rather than what the symptom is in isolation. And as a result, you have a more accurate clinical diagnosis and therefore management plan coming through. What have we not covered here in terms of the hip? Because I'm enjoying the exploration of of diagnostics here. Actually, it's a little different to what we usually do, but as a hip specialist, I think it's the way we should approach today's episode. So what else diagnostically do you think that we need to be clear on as physios?
I think in terms of our clinical assessment, I think that is probably one of the most important things, but also subjectively asking those questions. I want to make sure that I think we can just gain so much from that, from our clinical assessment, right? If we don't have a good subjective, if we're not asking those right questions on when their pain gets irritable, or how long they've had the pain, and how it affects their life and their concerns. I think just starting with that and getting that right can just be so helpful. And then diagnostically, I think being able to differentiate, let's say, a bone stress injury from a hip flexor injury can be hard, but if you've got the right language and the right skills to be able to talk a patient through something like relative energy deficiency, when we know that has a huge link to underfueling, and that will often show up in bone stress injuries of the hip. So I think if you can get the subjective right, that would be useful.
What's you mentioned you picked one up the other day, or you sent one off for a scan the other day. What got your spidey sense tingling around that one with the bone stress? What do you hear that's different to another musculoskeletal presentation?
Yeah, so I think definitely it's the history of what the patient has been doing in the last few weeks or months. So usually that's training for a big event, whether that's a marathon or another endurance event. And so if you have that history alongside a patient that starts talking about hip pain or anterior hip pain, or they think it's their hip flexors, then again, my ears kind of go, oh, and I start getting a bit nervous already. And then it's being able to ask those questions about cycle, about their periods, and feeling confident to be able to talk about that. And then from that, I would be wanting to then go into questions around how they're fueling and what a typical day looks like, and sort of what they're eating and food. And again, that's something we also have to be a little kind of cautious about how we're asking those questions, because that can come with sensitivity. I've had patients that obviously have a history of eating disorders and find those questions quite difficult. And so we do want to make sure that we're being, we're answering those questions, we're asking those questions, but we are making sure that we're being sensitive around that.
Well, once your clinical suspicion is sufficiently heightened, what do you do in the objective to differentiate?
So I will, first of all, I'll be looking at hip range of motion. I'll be looking at functional movements. And then I'm thinking about things like hop tests that can be helpful. Sometimes hop tests I've sent a patient for imaging. They've had a positive hop test. I think they're underfueling. I think they've got all the stuff and it comes back and that's not the problem. But if that is happening, then again, I'm thinking those are some clinical signs. You can also do tests like a fulcrum test that might be an indicator for a bone stress injury of the hip. So that would be one I would be looking at. And so I think it's about having your objective assessment alongside the subjective and bringing those together. But area of pain is a big one for me. And if they're waking in the night with pain when walking, I will often find that if somebody's had it's not the hip, but it's like a sacral hip injury or bone stress injury, they'll often have a sort of moment in time where they're running and then suddenly they can't run anymore. I've picked up a few like that where they've actually had to stop running in the moment.
I had one with a squat in the moment, squatting, not the craziest heavy weight, but they were lifting reasonably heavy weights, and there was a sharp pain that they experienced. To me, actually, initially, I thought it was going to be more hip joint related. When I assessed it, she came in and it was this. There was just this feeling in the room. I don't know I can't really explain it, but it was just this way that she was moving. This real fear about some of the tests I did with her. She really did not like that sacral thrust type, and I was still thinking, I've got a feeling you've done something to your hip here. I'm a bit nervous about this. I really think you need to go and get this scanned. And I could tell she was worried, but I almost wanted her to be worried.
Yeah.
I didn't want her to underplay the importance of going to get something checked, because I was thinking if she has got some kind of significant hip fracture or something that's gone on here, I need this to be checked. It turned out she had a sacral stress fracture.
Yeah.
And it did take her months to get better. But funny you said that, because yeah, she had a real moment in time as well with that squat. And there was a real, I guess because essentially it's like a red flag type moment, right? I really felt that. I could really feel it, that there was something different about it. And although it's the only one I've ever seen in my career, it was sufficiently different to what I would usually expect a hip joint pathology to be.
Yeah.
That I was very glad that I sent her off for imaging, and she did amazingly. I still see her occasionally when she comes in, and we remember that time. Do you remember that time? She's had a couple of other normal, because now she worries a little bit. So she comes in, I think it's okay, but obviously remember the last time, and I just want to check. And then we go through a few things, and a couple of times she's been in, it's been totally fine. It's just had a fairly mild, perhaps overload type injury. But yeah, that what I really wanted, the reason I wanted to really tell that story is the feeling that I had about that red flaggy type moment of this is different. And sometimes that's enough. Even if I didn't quite get the diagnosis spot on, I thought it was hip joint. It was close enough that I was worried to send her off.
Yeah, I think, that feeling is, if I ever get that feeling, I think that just warrants you sending somebody off, right? Or at least a clinical discussion with a colleague or something, because I think we're usually right when you get that feeling. Just going back to that sacral bone stress that I mentioned, actually, I should mention, because it was a patient that maybe we don't always think about this, but this patient was a female patient that had been breastfeeding, and she had been training or just getting back into running. And it wasn't until this patient that I realized that actually when you're breastfeeding, your baby leaches the calcium from you and makes you more at risk of bone stress injuries. And that's something, I wanted to highlight. I realized that, and I was like, that's so interesting. And I've only seen 2 sacral bone stresses. One was a full fracture. It was a sacral ala fracture from running. And then this lady who had, unfortunately, the bone stress, but she was breastfeeding.
Well, the lady I was speaking about was going through the menopause, so it's another specifically female situation here. So I think that's what's great about this episode is we're really going specific on, especially for like us ignorant men like me. It's helpful for us to, because we know the problem with research, right? We know that isn't it something like 90% plus of research is done on males, something like that?
Yeah. So
we have to have these deliberate conversations. And if a listener's got this far, they agree with us that it's important. But some might see it as like, oh, we're talking about women. It's like, no, there isn't the evidence and research available for us to just lean on that. We have to have conversations with experts in this world in order to get the real nuance to it. So I'm really pleased that we've been able to have this conversation. Great. It's been really good. What have we not spoken about yet that's important? What do you enjoy speaking about that's really relevant to this conversation?
I think it'll be interesting to talk a little bit more about, I guess, about my career maybe, and how I have also started not just doing my clinical work, but also doing a lot of different things as a physio, because I think, interestingly, I get a lot of questions about that often on my DMs on Instagram. Like, but I kind of put up like my schedule of the day, and people are always interested in like, oh, how are you doing that? That sounds interesting. Or how I got into teaching and that kind of thing. Because again, we mentioned before that maybe not a lot of women are maybe in teaching or in doing other social media stuff as well.
That's exactly right. We started it when I said, tell me about your journey, and then we got distracted. With all sorts of others. So it's actually quite a nice finishing point to kind of finish that journey off. So I guess that to some degree it's the moment when you're in private practice and then you get these opportunities or you reach out to people. So how did that play out? You go from a practitioner into this multifaceted expert within musculoskeletal physio.
Yeah. So I think, first of all, mentorship was a big thing for me, reaching out to other physios and learning from them. And essentially that networking has hugely helped me to open up doors into other places. So I work as well with a medical devices company as a tutor. They distribute shockwave machines, but ultrasound machines. So I'm able to do some tutoring around that. And that kind of got me more into teaching. And then I was teaching in different places for this company, and then I would meet other physios and they would be like, hey, why don't you come and talk about, I hear you're talking about gluteal tendinopathy in this shockwave conference, why don't you come over here and actually talk about gluteal tendinopathy here? And so that just opened up a whole area of teaching for me that I wasn't expecting. So that's become a big part of my career now. So I teach on courses. I've got a course coming up on advanced running injuries, actually, with Benoit Matthews. And I've been loving that, doing that alongside my clinical work, because I think if you're teaching something, it keeps you on top of what you're doing. If you don't, you have to look at the research, you have to be spending extra time on it. And if you can then answer somebody's challenging questions on something, hopefully you've learned it, and that builds your confidence and the expertise. So that's one thing I've been kind of doing, and on top of my clinical work, which I'm loving. But also social media has been a big part of it for me. So I think that's how I've grown as a physio. I put a lot of that to social media. So 4 years ago, I started posting on social media, maybe 5 now, and I would have maybe 200 followers and 1 like. But for some reason, I decided to keep posting, and that started to grow. And then I remember I got my first online client when I had something like 600 followers and not that much engagement at all. But after seeing that, I thought, wow, I could really make something from this. And so I continued posting, and that's turned into, I think, getting more patients in clinic, but also more opportunities outside of physio, whether that be some of the kind of some writing work I do, or coming on this podcast. And really it's opened up a huge amount of doors, as well as social media being paid for brand work and things like that, which is completely brand new to me and something that I'm only just learning.
Liz Bailey said a very similar thing about teaching. She said how powerful that was for her learning, and how it really spurred her on to go deeper and deeper on subjects that she really wanted to feel confident in the knowledge and in the research, and that in turn then drove to more learning, more courses, more learning, more courses. And
if anything, the teaching has built my confidence as somebody who was quite, maybe felt quite nervous around talking in public and also teaching. You'd think that actually that maybe wouldn't build confidence, but it's actually the learning that I kind of forced myself to do, because I didn't feel that confident on it. I kind of feel like I might have gone above and beyond to feel like so ready, feel like you have to know everything, and then that really then it does help you build confidence.
Yeah, for the listener that has enjoyed this podcast, that'll be another one. I would recommend the Liz Bailey podcast.
I love that episode
with dancers. She's another fantastic guest, and a good female role model as well.
Absolutely.
So, doing brilliantly. And where does someone find you then, Yasmin? Clearly on social media.
So I have an Instagram, and it's called The Fitness Physio. So you can find me on there. I've also got a website, which is The Fitness Physio. And that's probably where you can pick me up.
And we have a tradition on this podcast that we always ask our guests, what does better never ends mean to you? It's a powerful saying for me. It's my purpose. It's my why. It's something I established that was really meaningful for me in my early 30s, and it continues to drive me today. So what does that mean to you and your world?
It means always keep trying. Better never ends always means, for me, trying to better myself, to keep moving forwards, to keep doing things that scare me.
Such as this.
Yeah.
Oh, you've been amazing.
Thank you. Thank you. No, I loved it. It was great.
Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with Jane to see it for yourself. use code PhysioCoach2MO to get 2 months free. To stay up to date, follow us on Instagram at BetterNeverEnds or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's better physio.